Yeah, thank you for having me in this round. I'm very excited to join this first conference of its type. I think we heard some very deep dive into the methods, and Daniel has, as always, painted an excellent picture of where radiology is. What are some of the important questions? What do we need to make meaningful AI? My topic here today was to give more a bit of a practical experience from a radiologist's view. A very big topic, what to expect from AI in radiology, and I broke off a small piece and hopefully can give a bit of an overview of what we can expect through an educated guess of what we already know. So, sorry, taking a glimpse at the other applications of AI in different fields outside of medical imaging and outside of radiology, it is easy to get inspired and sort of have expectations to quickly see similar solutions in radiology. But when you look more closely, and this is some of the topics that already came up in the discussion just now, is that you need ask a lot more questions. Healthcare is a specific field, and it is not by accident that applications outside of medicine are not transferable in all cases to medicine. You need to think about the solutions differently. These are some of the many questions that have guided me in putting together this presentation, and there are obviously many more. So a lot of uncertainty still, but there are some things that we know that we can draw from. So let's first of all put the question directly to radiologists. I've tried to put as much of a perspective from surveys and sort of reflections of a radiologist opinion into the talk to kind of ground this sort of question, which can quickly get fuzzy if you just look at it from an academic standpoint. So what are where can we expect an impact of AI in radiology exactly? So we have these subspecialties in radiology, and a sort of recurring theme is these subspecialties. It's reflected in this is one of the largest, most representative surveys that we have. It was done on over 600 European radiologists. And it is also reflected in this survey here, showing specialties of cardiovascular imaging. Breast is a prominent nominee in these kind of questions. There's a lot of applications expected in chest radiology, meaning thorax applications, such as we have just seen for pneumonia and cancer detection. And then oncology and hematology sometimes comes up as its own specialty, and sometimes it's summarized in other specialties. And if we take a look, this is a summary that's very current and has been published in Radiology. What is already on the market, we see quite a good overlap of this short-term prediction, if you will, of radiologists seeing the most dynamic potential and what's already there. On the left side, you see the much harder to count applications. These are the ones that are not certified, and there's numbers in excess of 30 in some of these cases. You see the darker, the more applications are already available. Most of them are available for chest CT. But if you go through the list that we just saw, it matches quite well. Neuroradiology was a prominent one. So we have these applications here. Breast mammography and breast imaging has been a promising application field. In chest, you have a lot of conventional, but also CT applications. And then it sort of gets a bit thinner. Cardiovascular applications remaining amongst the top, and then oncology is not listed as its individual category here. It's a lot less applications if you actually look at certified solutions that you can already buy and that have some sort of label and undergone some sort of testing, in this case, FDA and CE approved offerings. However, the distribution is quite similar. So these are more or less research applications, or a bit more towards commercial use, and these are the ones that are actually certified, and they reflect quite well. I will look at these a bit more detailed later on in the talk. So what about the state of autonomous use of AI in 2020? This was sort of a second question to me. How many apps can we count today that are ready for autonomous use, and should we count any? And the question, the answer is a clear no, from both of the largest radiological societies that have responded in a joint letter to an open workshop of the FDA. I will touch this also a bit later in the talk. And basically brought these two prominent statements. First, that is their strong belief that it's premature to consider any approval or clearance of algorithms that are already autonomous, independent of a physical expert, and that it's very unlikely that the necessary assurance and basically safety can already be provided by the FDA for using AI in radiology by itself. However, on a side note, some of the potential uses are also noted that are promising in the eyes of these representatives of the society, meaning those chronic diseases that could otherwise be overlooked and could be quantified by AI. Pulmonary emphysema being a prominent one, hepatitis cirrhosis, high BMI was actually listed here. I think not so much as an incidental finding, but as a quantifiable disease that occurs without it being the main focus of the examination, and then osteoporosis. Staying on the topic of autonomous reporting by AI, who should actually take responsibility? So we heard the opinion of the state of autonomous AI tools by the big societies, but what do the radiologists themselves think? So again, this is the same survey that I quoted earlier. The overwhelming majority of these radiologists, first of all, said that they do not see patients accepting these results, and or said it's too early to tell. So sort of in line with the societies. In my own opinion and in my experience, these are some of the applications that I already see in broader use that are not necessarily used autonomously, but that have already built a staple in providing a report that is then signed off by a radiologist user. If we look at a recent survey amongst radiologists that were taken from all fields, which is why this is an interesting feedback, and all different workplaces, so not just clinics and specialty centers, but also from practices. Only 65% of radiologists actually use some sort of AI already in daily practice. And it becomes even less of an important number if you look at the sort of exposures that are listed here, which are quite general as enhancing image quality, but also include decision support, automating part of the image analysis, optimizing the workflow, and tagging images, which is often referred to or comes in the form of triaging tools that give sort of a hierarchy of unread images. So you read the most important image first. Actual exposure to these use cases was quite low in percentage in this group, and even less regarded themselves as very familiar with these applications already. So this kind of shows a bit of a storyline already. On the other hand, we have almost an explosion of startups and a growing selection of AI tools that are commercially available. I've just picked some at random. There's no association with these vendors, but it's interesting that amongst the use cases that I stated earlier, we had a very prominent driver by a RSNA challenge that provided a large data set for bone age estimation. And it has sparked a number of improvements in solutions. So there are some openly available ones. And then there is publications on how these could be improved upon. Then here's another interesting example I've taken from a publication from 2019, which quite visually shows the benefit of why cardiovascular is such a promising application, because it's quite time consuming to do these segmentations and volumetric analysis, and the speed up potential is very high in neural networks. So you have a large number of suites addressing just that, and a very, very colorful range of different vendors. This is just an example taken from the last year's RSNA. If you look at 119 different software offerings that are already purchasable in this broad classification, most of them enhance the diagnostic ability of the user. And the next largest percentage is quantitative in nature. And then only a smaller part address repetitive needs. There's a different classification that I did, and I will show in a little bit. However, amongst these new software solutions that we have, there's a new generation of AI computer-assisted diagnostic tools. We saw that diagnostic assistance is a very large percentage of these. It's a focus, obviously. So I think chest cuts are a good example because they're amongst the very oldest of applications for assisted diagnosis. And this publication shows well sort of the evolution. First of all, they're quite comparable to radiologist readers, which is often the case in these smaller studies. And of course, you can ask how representative is this? They are obviously much more robust, and they have new features to older DNA, to older cuts. For instance, this one could take the prior CT volume into account, an aspect that was touched on earlier when talking about disentanglement, that this is mimicking the way that radiologists use images to make decisions. It's more interesting, however, if you look into the discussion of the classification performance of this cut. So first of all, what was it looking at? Obviously not the same categories that radiologists religiously used by recommendation to classify these lung lesions, which is the lung-RAD scoring system. So the network was actually free to pick its own criteria. And in some examples, it could be deducted that these were features outside of the main nodule, which is not taken into account in the radiologist reading. And the authors of the paper didn't exactly, weren't able to specify what risk features were taken into account, obviously. But this goes to show well, I think, to illustrate the value or also the caveat of these new diagnostic tools, especially when you take into account who should be responsibility of the outcome of this decision. So again, we have our representative, almost favorite European radiologist group now, and half of this large proportion says it should be the radiologist alone, or it should at least in part be the radiologist. So shared responsibility, that's not classified any further, but it could be the vendor or could be insurance companies that are addressed here as a shared responsibility carrier. If you put this together with a recent law statement that I've taken here from a professor on law, there's not even a sort of a procedure yet, but it's being discussed to have a fictitious electronic person that could take the responsibility for an AI tool. The answer is not generally easy, but it's not the case that somebody else has taken the responsibility for the doctor here. That's not to be counted upon. So taking this together, it sort of makes clear what the challenge for the radiologist is currently. And when is the consultation actually happening? So what is the actual decision that the radiologist is reaching, and why is he actually being sought out? So this is a sort of a chronological order of typical use cases for radiology. So we come from prevention, that's prior to the actual diagnosis of the disease or screening for occurrence of disease, all the way to understanding why a person died in forensic radiology. And I've written some examples of typical tasks that fall into the categories that we have seen earlier to illustrate that all of these processes can benefit from AI and from automation. And it's easy to explain why. It's because it's basically a digital process that can be broken down into subtasks, and these subtasks are automatable. The question is, how welcome is this automation? And it comes down from the radiologist's perspective to a concept that's been in discussion for a while. This is an 8-year-old paper that touches exactly these points. And the concept was named sort of a thinking of an information business model versus a professional service model, which is the traditional way of thinking. What we heard earlier is, as a radiologist in a professional service model, you're basically paid to provide a consultation in form of a written report, and you sort of decide how to get there. And image generation is a necessary part, obviously, but many of the other post-processing tasks are sort of left up to you, and they're not reimbursed specifically. They are therefore not incentivized and not motivated. And it's sort of, the system is suggesting to go the way of least resistance. Whereas in an information business model, it's not necessary, it's not entirely up to the radiologist, of course, but on a definition level, you basically see the entire process as smaller sub-processes, and the product is generation of information, which can then be reimbursed specifically as a subtask of the radiologist value chain. And it becomes much more easy to outsource and automate individual pieces of this workflow. So the thinking is no longer read images, but the purpose is to create information. Now, taking further putting ourselves into the shoes of radiologists, what are their perspectives on AI and their developments? I've chosen this publication because I think it's a very interesting perspective to put computer scientists and radiologists sort of head to head and analyze and show a difference between and the overlap of both views. So first of all, we can see that radiologists are generally favorable towards AI. They would do again what they've chosen, pursuing the role of a radiologist, the profession of a radiologist. Most of them are eager to learn about AI, and most of them would also be willing to help create or train AI to automate processes that they do themselves. Both groups also agree that generally radiologist job satisfaction, salaries, and the role in society will largely stay the same or even improved through AI. There's a bit more of a difference if you look at the expectancy of dramatical change or significant evolution of radiology through AI. So radiologists are a bit more conservative in their expectations in the short run, and it becomes more similar if you go longer than 10 years into the future, whereas computer scientists sort of seem to put more confidence in the impact these methods can have in radiology. And that's a bit of an occurrent theme. This has been a change in the last years. I think the fear of replacement is overall gone. there's still some individuals believing that it will be the case in the not so distant future. Here's another motivation that is partially overlooked, maybe a bit less talked about in European radiology, but has become sort of an important factor to consider. There are some representative studies showing the prevalence of burnout in radiology. While it's analyzed as a multifactorial process, and a very common cause that's being put forward is the rising case numbers and the rising number of complex cases, whereas the time, as we heard earlier, is being limited and mostly staying the same. Not surprisingly, also this problem has been addressed and suggested to be solved through AI. There's a whole range of digital solutions that's being put forward in this analysis, but AI automation through CUT, decision tools, diagnostic decision tools, and automation of routine reporting aspects through AI rank among the top AI applications to help burnout in radiology in this case. So we've seen a bit of what AI can do in radiology. And let's look a bit more about what we can actually do and what we have already seen in terms of products. So this is just the volume of publications in AI. It's vastly growing, and you can see while we had an excess of 1,500 last year, it seems to be growing exponentially still, and we're already past 2,000 publications this year. I've just taken examples of the different applications that we had earlier from last year to show that basically all the use cases you can think of have more or less been addressed in this range. And apart from that, we've also seen a lot of new promising applications that are not been put into use yet in a practical sense, or are about to, but are currently sort of promising research applications on top of what could be commercialized presently. But if we take another look, and maybe this is the more filtered, more interesting one, what can you buy that already has a certification stamp on it? In this analysis, which is recent from this year, the authors have sorted through FDA-approved machine learning and AI, so deep learning applications, and chosen only those that are clearly labeled as such, which is not the case for a lot of apps and software, and it's not necessarily required even for the certification process, which is why you get widely different lists like these. You can see, however, that most of these apps are aimed at a radiology audience. And then there's a number of subspecialties, cardiology and oncology being the most prominent among them. This publication is interesting, I think, because it comes with an interactive website, and you can browse through the apps which are being updated continuously. And then it lists here the subspecialty and gives you a description for each also and a link. So by going through these manually, I found 70 apps. This was done in October. Of them, 50% were for radiology, and within radiology, radio-oncology being the largest percentage. There's also a few problems being put forward by the authors and illustrated by sort of sorting through the apps like these. And it's, first of all, a lack of labeling of the methods that are used, which I just mentioned. And there's a lack of certification processes to actually take continuous learning algorithms into account. This has now been proposed by the FDA in a publication in 2019. It's called Total Product Life Cycle Certification, and basically could support continuous learning, whereas the standard way of looking at algorithms is to expect the same result each time for a specific input, which is not how these newer continuous algorithms work. But it's a step in the right direction that's been put forward already and that we could expect more of. This is a different list by the American College of Radiologists, and the numbers are a bit different because the inclusion criteria vary in all of these different listings. But this one is interesting because it gives a bit more functional description of the algorithms. And counting these, I found most of them in quantitative analysis, so deriving a quantitative measurement like segmentation or volumetry or similar. And the other one were workflow improvement tools like triaging and flagging. And there's actually been quite a larger number recently put forward of these. And then the third largest would be detection assist, which we already saw earlier. So we can basically put into these categories what we already have, what research is showing, and it's image generation has not been talked much about in these previous slides, but I think it's a clearly promising field. We have a new generation of reconstruction algorithms. There's a lot of faster MR acquisition being put forward, artifact reduction and such are being shown. It's also something that I think radiologists that are asked about deep learning are not aware of, or would not specifically state much of using. Similarly, automation of simple repetitive tasks can be as simple as windowing settings or hanging protocols that are not necessarily labeled or understandable as deep learning applications, and certainly not in the way of autonomous reporting. We're seeing more interest and more dynamics in the detection and quantification, quantitative tasks for diagnostic assistant tools. And the next step would be decision support, such as predicting and generation of imaging scores. How about a combination of these features? So there are platform approaches, and I think it's fair to say still that these are in an early phase and not subject to widespread use, such as I could talk to 3 different colleagues and they would likely be using the same platform, which puts us in Horizon 1 in this market analysis. I think this is a very interesting sort of digestion of the development of the AI market. And it basically puts forward the following 3-part development. From what I've presented in the current sort of listing of tools, it follows that we are in Horizon 1. So we can see a lot of different parallel solutions that are very specific to individual problems. There's a lot of AI startups, there's new emerging players, and there's heterogeneity in the market, such as there's no winners that have sort of taken large portions of the market for certain use cases. The next step would be improvement of the certification process that's being foreseen here. So we've seen some hints of that, but it's certainly not in the state. I've talked about FDA approval. I haven't talked about the European approval, which has the same problem and basically not put forward a solution there that's comparable. And finally, the step to really kicking off the widespread use of AI would be reimbursement and acceptance by the insurance companies and payers of the services in healthcare. So coming back to the time frame, when can we expect this widespread in radiology? Most radiologists seem to think in the time frame of 5 to 10 years. Some are a bit more cautious, but quite a few actually already see it happening in the next year or so. So why hasn't it already happened, and what is the biggest sort of hurdle to overcome to really let AI be spread amongst radiologists? And it's basically the lack of trust. You could say it's a lack of transparent AI methods. So sort of like home appliances that we know that sort of work autonomously and work well most of the time, but we wouldn't leave them alone in our home, maybe because we had one or few bad experiences with them already. But it's not just the transparency, but it's a different perspective that we as doctors actually have chosen as the basis for evidence-based medicine, and that's the body of studies supporting the use of AI algorithms. If you, in this structured report, in this comparison, basically, there's been a broad analysis of what's already being published, and the authors only looked at those deep learning algorithms that have been compared in a clinical setting, where a patient actually sought a real clinician for an actual medical problem and was being helped. So actual deployment in a pathway. There was only 8,000 studies that were eligible for that. And of those, only 81 then were included in the study. It came down to 2 randomized controlled trials, which is the gold standard for trials that would change the way that recommendations or guidelines are being updated. And of those, only 1 study was in radiology and was ongoing during the manuscript publication. So 3 points to take away from that, apart from the obvious lack of randomized trials, which are the decision basis for changing the way things are done in medicine, is that a lot of these studies actually had poor adherence to reporting standards, which have recently been put forward and directly addressing the needs of AI reporting. And there was a strong overconfidence of reporting results despite their methodological lacks. For instance, studies claimed that AI tools were now ready for clinical use when actually they hadn't been tested in a large representative setting. So looking at the other aspect of making radiologists comfortable with AI tools is how much are they actually being helped to use them, how much education is being given. And there's, in sort of all of these overviews, there's a strong agreement and sort of desire for an intent for AI teaching and training. And there's been basically no inclusion in the regular training methods so far, neither for medical students or for the specialty training and beyond. But there's a recent solution to this also from RSNA that is now, I think there was 3 students in the preliminary arm that had as a test received additional courses during the specialty training, and is now sort of being modeled as a data science pathway that can assist radiology residents to get more specific training on AI. So this is my wish list, so to speak, of what I have gathered that stands in the way of adoption of AI. I think these are the sort of the framework updates that are needed. So we've heard this previously, but organized medical imaging data is actually what we need. So a lot of imaging data isn't necessarily much more helpful than having the right amount of good data. There's a strong need for comparable data sets. We had the example of different vendors having to be used in one data set, and there's a plethora of other factors making these data sets incomparable in cases. There's a strong lack of infrastructure projects. So it's not very easy for physicians to share their data, pool them together, and at the same time adhere to data protection laws. There is now representative reporting standards, basically, for trials to adhere to, but we need more representative trials to actually adhere to them and give us the basis of proof that is needed to actually change medical decision, taking AI into account, and to allow for their use more widespread. There's education needed to make educated users out of doctors that have not been deeply in touch with AI in their training. And from a summary of these, the guidelines could be updated. Overall, we need declaration of tools. If we expect doctors to make decisions, they should be in a position to understand whether or not it's actually suited for the specific use and what they're deciding on. This has been made a point earlier as well, and I think my answer would be yes, it could help. But if you're talking about the time frame, it's very unlikely to come much quicker than other AI methods. But as you can see in this impressive study, there's been a lot of prediction capability from just having, in quotation marks, just having the health records without the imaging data itself. I think the biggest driver, in my opinion, will be reimbursement. And this is a good example of why. There was computer-assisted diagnostic assistance tools way before the current generation of AI tools based on older machine learning methods, and they became available before the 2000s, actually, for this tool set, and then received a reimbursement code that was worth in the range of $10 if they were used as a second eye of digital pairs for mammography screening. And you can see how rapidly they spread to almost total saturation for mammography screening. And there's been a number of studies that at the positive range have shown no benefit. At the negative range have actually shown next to the financial burden for the healthcare system, reduced accuracy, and even higher biopsy and recall rates. There is a comparable development for our current use of AI with the actual generation of deep learning methods. This one addresses stroke treatment and the reading of CTs with an AI tool. And there's a few years back been an example that we can sort of take to see what these kind of reimbursement methods can do. So this autonomous retinal scanning and reporting has led to a number of solutions after its introduction. So this could be a big game changer for development of AI and their use. If you continue just looking where the money is going, there's no lack of reports predicting the AI market, and all of them speak the same language. There will be a drastic increase, and there's been one discrepancy, which is the impact of COVID-19 and the pandemic. Some reports are predicting a bit less of a growth in the coming years. Some are saying it's actually a benefit to AI use because of the necessity. And there's been a large number of use cases that most of us will know. Well, this one is taken from Radiology itself, and it basically predicts further growth. Taking a step further, what do customers that are looking to buy AI actually say? And we're about to see the next gathering of RSNA, this time virtual and not physical, as a physical congress. But in this survey, 100 users or RSNA participants have been asked, and there's a bigger percentage now actually looking for the solution. So suggesting that maybe the market is a bit more ready, and we'll see in the next year how that actually develops. Sort of a side note towards the end of the talk. We've mostly talked about regulations and applications that apply to the United States, because that's where most of the startups, most of the approvals also are. It will be for time to tell if we see a change into these regional areas. And I think it could happen because these external dependencies that I've tried to sort of play at in the last slides are necessarily different in these regions. Also, we have different roles that the governments are playing in funding AI in the public sector, but also supporting industry. And we have different rules and sort of frame sets for collaboration of industry with healthcare providers. They will necessarily be different because the patient collectives are not comparable in many cases. In my personal summary, when asked about autonomous radiology reporting, I think what we will see in the foreseeable future, so say in the next 5 to 10 years, is the analogy of driving a car. So we will get used to having assistant apps and navigations. We will learn how to use them well. And we will probably see some capabilities that can enhance driving, such as automated braking systems. But I don't think there will be enough comfort to sort of let go, or enough trust in the technology to actually have autonomous radiologists reporting in the next years. It is consensus that medical imaging will undergo lasting changes. It's reflected in basically all the literature. The big question is, when will we actually see it take off? And I think due to the external dependencies that I tried to explain a bit, I think it's largely underestimated. It might be more underestimated if you look at it outside of healthcare, as opposed to as from a practical standpoint and a user standpoint itself. There is a continuous growing volume of better, smarter applications that can help radiologists. One of the quotes has been that radiologists won't be replaced by AI, but radiologists that use AI can replace radiologists that don't. We need other beneficial sort of support for these radiologists, such as training, to be able to make them good users for AI and responsible users. And I think, as in the analogy of the car, for the actual medical decision and the quality of the medical process, it will still be a human driving the entire process, and not autonomous AI applications, at least in the coming years.